So my talk is going to take on from the acute heart failure talk and talk more about the chronic management of heart failure. I have no declarations with regard to this presentation. So I guess I'm covering some of the ground that's already been covered by the earlier speakers, but just to put into context the importance of the management of chronic heart failure and the severity of the illness, and it has a significant morbidity, and over 5 years it's very similar to most common cancers. And looking at the evidence base that we now have for the treatment of heart failure, we all have it within our grasp to make a huge difference to a patient's quality of life and also their survival with early diagnosis and prompt implementation of appropriate therapies. Again, maybe a familiar slide, but one to highlight. And this is because heart failure, although it is a treatable condition, for most people, it is incurable. And the importance of early recognition and early treatment is preventing recurrent hospitalization and an inevitable decline in a patient's function, which ultimately leads to their death. And treating heart failure upfront with appropriate therapies improves people's quality of life and survival. And it's our challenge as healthcare providers to do the best for our patients and to ensure that we've got them optimally treated. So running through the classification of heart failure, this seems a little cumbersome, it seems a little complex, but there's good reasons behind these divisions. And it's basically breaking down heart failure into divisions based on ejection fraction. The reason for doing that isn't necessarily because of the severity of the heart failure. We know in patients with heart failure and preserved ejection fraction that the mortality is very similar to people with reduced ejection fraction. The reason for making the division is very much to look at treatment and therapy, and we have good quality treatments for heart failure with reduced ejection fraction. We have some extrapolation into the mildly reduced ejection fraction group, but unfortunately still limited therapies for patients with preserved ejection fraction. And the group of patients with preserved ejection fraction are often overlooked and undertreated. And I'm going to be guilty of that in this talk because I'm going to primarily focus on the heart failure reduced ejection fraction group, because that's the group of patients we have the best therapies for to prolong their life expectancy. So if we were to look at the treatment options, I'm going to start with the preserved heart failure group with preserved ejection fraction. So this is primarily a condition where we have either thickening of the myocardium or some problem with the relaxation of the heart. It's supported in its diagnosis with symptoms, elevation of natriuretic peptides, and other key features on the echocardiogram. Important things to remember is the ejection fraction is not always the answer, and the very important pieces of information on an echocardiogram report that never should be overlooked or dismissed. In particular, measurements of filling and filling pressures and pulmonary artery pressure, and also to go along with that, measurements of left atrial size, because in the preserved group, you'll probably find abnormalities in all of those measurements. Up until recently, the key treatment has been focused on management of comorbidity and symptoms, so diuretics to alleviate breathlessness and fluid retention, management of hypertension, and also treatment of other comorbidities such as COPD and type 2 diabetes. There will be changes forthcoming because we've had the publication of the Emperor Preserve clinical trial over summer, and this is really the first therapy from a randomized clinical control trial to show evidence of reducing heart failure hospitalization and mortality, and so that will go to the National Institute for further appraisal. Skipping to the other side of the chart, the heart failure with reduced ejection fraction. This essentially is where we have all of the class 1 data from the large-scale randomized clinical control trials, starting with ACE inhibitors, which have now been with us for around 30 or 40 years for the management of this condition, to more newer medications such as Succubutural Valsartan and dapagliflozin. I quite like this slide. It really gives us a history of heart failure management for patients with reduced ejection fraction. The first thing to say is that if we were giving this talk in the 1980s, it would be a fairly short discussion and we could break for lunch a little earlier, because we would be saying the treatment here is very much guided towards diuretics, symptom control, and there may be some trials coming our way looking at ACE inhibitors, which may impact on mortality. But as you'll see, as time's progressed, and with multiple randomized control trials looking at different therapies to block the renin-angiotensin-aldosterone axis, we've made significant inroads into the management of heart failure, reducing not only mortality, but reducing hospitalization as well. In terms of their sequence of publication, we've had ACE inhibitors since the late 1980s, showing a substantial reduction in heart failure mortality. Then followed by the publication of spironolactone in the RAILS trial. Thereafter, into the next millennia, we've had multiple studies of beta blockers showing further reductions in heart failure. I said to Dr. Rao I was going to steal one of her slides. So I'm going to talk a little bit about devices and nod my cap to John McClelland's and the CARE-HF publication in 2005, showing this in people with optimal medical therapy. If they have baseline dysynchrony, which essentially is left bundle branch block on their ECG, you can further reduce mortality with biventricular pacing. We haven't stopped our efforts, having initially exhausted our avenues of looking at medical therapy and gone into the world of devices. Subsequent publications, such as the Paradigm HF trial, clearly shows a further reduction in heart failure mortality compared to an ACE inhibitor, which historically has been the gold standard of treatment. And if I could just get my pencil and etch it a little further to the right-hand side, there'd also be a column there for dapagliflozin. I haven't neglected it. It's got a slide coming later. So just to highlight the Succubutural Valsartan, it's randomized controlled trial of Paradigm HF, and it's taking on the long-standing gold standard treatment of an ACE inhibitor and enalapril. And people often ask, why enalapril? Well, if you go back to the original studies that have published and the solved registry, most of the research in ACE inhibitors was done with enalapril, and so that's why it's the gold standard to compare new therapies. But what you see with Succubutural Valsartan is a significant reduction, not only in heart failure hospitalization, but also in mortality. So in your patients with severe left ventricular dysfunction, even if they have minimal symptoms and they're sitting on an ACE inhibitor, you now should start to feel uncomfortable because they're no longer on the gold standard of treatment for their condition. And there are ways of reducing this patient's risk of hospitalization and reducing their mortality by upgrading their heart failure care. And to get people onto Succubutural Valsartan, it has to be specialist initiation. So you need the help of your cardiology team to initiate and prescribe this therapy in the initial stages. This slide talks about Sglt2 inhibitors and gives a little bit of the background on this group of medications. If my memory serves me correctly, there was initial concerns about several classes of medication for the management of type 2 diabetes. And this really goes back to rosiglitazone, which is one of the classes of medication used for the treatment of type 2 diabetes. And thiazolidinediones, not easy to say, is one of the group of medications where there was a clear safety signal with regard to an increase in heart failure mortality with that group of medications, and it's no longer available for prescription within the United Kingdom. On a similar theme, there's also a safety signal over saxagliptin, which is a fairly commonly prescribed medication, or certainly a class of medication for the management of type 2 diabetes. With such grave concerns over cardiovascular safety, all new diabetic drugs need to go through a process of safety and clinical trials before they're licensed. And having gone through those trials, which were published around 5 years ago, there's a clear signal in the data that these medications have beneficial effects not only for the heart, but also for the kidney in reducing heart failure hospitalization and also protecting renal function. So there was then no surprise that further clinical trials were conducted in people both with and without type 2 diabetes to look and see if Sglt2 inhibitors reduce both heart failure hospitalization and mortality in people with heart failure. And just to give you the headline from the DAPA-HF trial, and that showed on top of optimal care, which could be Succubutural Valsartan or an ACE inhibitor, a beta blocker, spironolactone, and also device therapy, there's even further inroads that can be made in optimizing people's quality of life, but also improving their survival. And you'll see a fairly low number needed to treat of 21 people to reduce one event. And again, it's important that we highlight that this group of medications requires a specialist authorization to prescribe this medication. So with the transition of heart failure care, it's more important than ever that the patients in the community who have heart failure with reduced ejection fraction are very much tied up into cardiology MDTs to ensure that they're on the right medication and to allow that platform to initiate these therapies. This slide's taken from the European Society of Cardiology, and it nicely harmonizes all of that information into one slide. And starting with the initial phases, having diagnosed a patient with heart failure and reduced ejection fraction, the simple key steps is very much on lifestyle and alleviating symptoms and removing excess fluid. And so that would include fluid restriction, a low salt diet, and also loop diuretics. And having got over the first hurdle, we're then very much into the work of introducing, implementing, and up-titrating prognostic heart failure therapies. Although we now have 4 clear classes of medication to treat heart failure, it's imperative that just focusing on one medication, up-titrating them, is no longer the gold standard. We should be looking to get our patients onto all 4 of these groups of medications. Just to say, without spending too much time looking at devices, that devices are for people with optimized medical therapy. And compared to the initial publications 15 years ago, the goalposts have now moved, and so is the what we accept to be gold standard of optimal medical therapy. So before we get into the realms of thinking about biventricular pacing or implantable cardiac defibrillators, we've got a lot of base work to do to make sure we've got the medications sorted. This is just a proposed algorithm by John McMurray, and it's just really to try and turn the convention a little bit on its head and say it's less important whether you start this patient on a beta blocker or an ACE inhibitor as first-line therapy or what algorithm you run through. What's important is that the patient's given the opportunity to get onto all 4 prognostic heart failure therapies and that we look to ensure that they're prescribed to optimal dose and strength. So moving on to our local heart failure pathway, the first thing to really look at is that it's well set against the national and international standards for the management of heart failure. And one of the key components is specialist assessment to ensure that we've got the correct diagnosis. We're happy with a treatment pathway for the patient, and we ensure that we've incorporated the patient into our heart failure system and that we work collaboratively both in primary, secondary, and tertiary care to get the best outcomes for our patients. I've touched a little on the left-hand column where we talked about heart failure with relatively preserved ejection fraction. This can be made based on the results of the echocardiogram, the clinical assessments, and the measurement of natriuretic peptides. But it's important that we look primarily at comorbidities for this group of patients to ensure that we've got them fluid balanced and that we've looked at treating their comorbidities, because often conditions like hypertension will drive heart failure with preserved ejection fraction, for example. In our patients with heart failure with reduced ejection fraction, it feels a bit like Gaudi's Sagrada Familia in Barcelona. It's a never-ending piece of work, and there's a lot of work to do in terms of initiating therapies, monitoring, checking blood pressure and kidney function, and also looking to respond to patients and their blood pressure. And it feels like it's a constant work in progress, and that's why monitoring of these patients beyond the initiation of therapy is so important. Just a few things to point out. There's now an option to initiate Succubutural Valsartan in de novo patients that don't have ACE inhibitors if they have severe left ventricular dysfunction. And I think a lot of what we need to do in heart failure pathways is take out the repetition of slow incremental up-titration of medications such as ACE inhibitors, which is a very time-consuming and labour-intense process, and we need to simplify that. And one way of doing that is to use a medication like Succubutural Valsartan. Most people starting on the 51 milligram dose, and then there's only one further up-titration thereafter. Just moving across to the next slide, which kind of adds on to the previous slide, and to say, if you thought that the story ended after the main 4 pillars of treatment, then there are other therapeutic considerations for patients with heart failure and reduced ejection fraction. So considerations for medications including ivabradine, which may help to reduce heart failure hospitalization. Digoxin mainly is a palliative medication for reducing symptoms of breathlessness, and then also tying into advanced heart failure therapies, which is one of the next discussions. I'll also give a quick nod to iron therapy, and for a vast number of our patients out there with heart failure, irrespective of whether they're anemic or not, they will be iron deficient. And there's very clear data that intravenous iron replacement therapy improves symptoms and exercise tolerance. And as much as heart failure is about mortality, it's also about quality of life. And that's certainly one area to consider once we've gone through the initial pathways of optimizing heart failure care. I wanted to spend some time for the rest of the talk talking about heart failure MDTs, because it draws together the secondary specialists along with our colleagues in primary care. And I like this slide because it draws out the fact that the management of heart failure is not simply all about tablets and medication. It's very much about collaboration and good quality care, communication, and ensuring that we all work together collaboratively to improve the quality of care for our patients and their outcome. And if you look at the mortality impact for an MDT, it can be as effective as many of the therapies that we're prescribing. So if you have patients out there with heart failure and reduced ejection fraction, thinking would they benefit from an MDT review, in particular for thinking about therapies and medications and optimization, I strongly encourage that. If we look in the secondary care team, generally it's composed of a heart failure clinician as its lead, heart failure nurses, and also an individual with a particular interest in prescribing. And that's really important because of the potential for the number of interactions between medications. But essentially, the things where this excels is in diagnosis, management of acute decompensation, and also considering specialist interventions. In primary care, obviously there's our full team of general practitioners, practice specialists, and also pharmacists, and very much looking at the monitoring and up-titration of heart failure therapies, but also considering the impact of heart failure on quality of life for each individual patient. My MDT has representation from palliative care, and I think as patients go through their heart failure journey, sadly that becomes inevitable, and what we would do is work collaboratively to ensure that patients with advanced heart failure are also well treated, and just because their symptoms are progressing, we don't negate or overlook end-of-life planning. Cardiac rehabilitation, I think I have a slide coming on that next, which really highlights the importance of rehabilitation, not only in patients with reduced ejection fraction, but also with preserved ejection fraction in improving quality of life and reducing heart failure hospitalization. Things to consider from 6-monthly reviews, so optimization of medical therapies, progressive symptoms, and whether we need to consider cardiac rehabilitation or if there's other comorbidities which can be optimized. Cardiac rehabilitation, so strong evidence base to reduce admission, and admission leads on to mortality, improving people's independence and quality of life, and making it available for patients with all ranges of ejection fraction. So just to tie up and to summarize that we've got a serious chronic condition here with heart failure. All the strands are saying early diagnosis and treatment improves quality of life and survival. To get patients onto optimal therapies, the input of MDTs and cardiology clinics for assessment, initiation of specialist therapies such as Succubutural Valsartan and dapagliflozin is imperative, and also the value of cardiac rehabilitation. And just one final thought. If you're seeing your heart failure patient with reduced ejection fraction and they're not taking all of those medications, is your patient truly optimized? I'll leave you with that thought. Thank you.